You kids are soft. You lack discipline.
We landed on the moon!
You didn't earn the knowledge for yourselves, so you don't take any responsibility.
It's like we've forgotten who we are. Explorers, pioneers.
I think this is episode 35. It seems like we've done way more of these than 35.
Yeah, I
We started doing this.
I feel like
Maddox
I've done
porn.
35.
Yeah. There's jokes in there somewhere. I'll just leave those alone. We're doing this podcast because I put out a little what would you like to hear on the next week in review, and one of our favorite patients here at the farm asked, will you kind of explain or talk about why it's different to see you versus an orthopedist? So we kind of just took that into why is it different to see us first versus second, or even, us versus another chiropractor PT. Not that we're necessarily better, but maybe different. And then our process may be different. So that's all we're trying to kind of explain is, can we be clear as mud on why you should come to somebody like us first with musculoskeletal stuff, unless you have a bone sticking out of your leg, you can't walk, or your intestines are hanging out of your abdomen. But we've actually helped people with that too. So who wants to go first? We should have had an arm wrestling.
You said you were going first.
Well, no, I said I was going to do the intro, which always comes first because it's an intro.
Okay.
I guess I should ask first, do we have any updates on patients that are pertinent?
Not the last one.
Patient that we talked about in the past, I guess I should have went and looked at what episode came in today. She just won the 400.
Oh, yeah.
And she
That was
leaves
the
for
lower
state.
Tibia.
Yeah, previous dancer, working on foot control stuff, but she basically just won the 400. She'll go race at state in the
4 to 8.
The mile.
4 by 8. She didn't run the mile.
Oh, she didn't? I think she is, though. Maybe not.
No, they should
I
run
don't
the mile.
She's doing well. Anybody else?
That lady she had her OB appointment.
Yeah, she get an ultrasound?
I haven't got the report back yet.
They
So you
didn't tell
have
her
no
anything?
update?
Yeah.
Nope.
Thanks for that update.
Yep.
I didn't have a case last time, but they're doing great.
You're going to have to be way
I
up.
didn't have a case last time, but they're doing great.
As all Daniel's patients. Daniel never has a miss, bad day. He's never had a foul ball in the clinic ever. I did hear he had a couple of errors during the game last night.
And one. Second.
It's actually
Perfect play.
Actually, I'll get us started. So what we're trying to do with this is we have 4 different examples of how triage went backwards or forwards. And what I mean by that is, was somebody starting maybe higher up in the trust tree, which I put a video out on that on YouTube here a couple weeks ago, which we'll put a link to. Or were we working with somebody that started conservatively and we ended up having to refer them out to another provider or work up, the orthopedic neurosurgical consult route. So here, it was almost exactly a month ago, a runner came in that is a extremely high level runner, is already committed to a Division I running program and is in his senior season. And he was just on the whole story with this runner was he took 5 days off after outdoor season or after indoor. Or he didn't run indoor at all.
It was after indoor.
Yeah, I think it was after
Cross country. Yeah. Took 5 days off. His brother came home. They did a workout together and he had some lateral foot pain. Well, then he took a day off, went out to run a day or two later, and the pain was pretty bad. So he immediately goes to an ortho. Ortho does an x-ray. They don't really find anything. They do an MRI. They show edema in his cuboid. If you know anything about lower extremity injuries, a cuboid is a weird stress fracture area. In particular, just show up with no repeated pain or trauma, even though he just run entire cross country season. So they put him in a boot for 2 weeks and they just had him on rest for another, I want to say 3 to 4 weeks after that. And then they started getting him back into, he was doing PT at 2 different PCs, one for strength conditioning stuff and one for physical therapy. And then was starting to do Alter G runs and came into me because they had done a follow-up MRI at 6 weeks after the boot and the rest and the PT. And it showed the exact same amount of edema in the cuboid and I think a little bit in the fifth met. So they come into me kind of what are we supposed to do here? I'm still having a little bit of pain. I'm, barely running an Alter G. And his father and him both already kind of said this doesn't make sense. It doesn't seem like stress reaction or stress fracture to begin with. It's definitely not responding like that. Why isn't it healing? And I go, this is maybe one of those cases where you started at the top. You went to an ortho because you had a little like pain in your foot and you're an athlete. I'm not saying that's the wrong move. It's probably not just going to save you money or time, right? Might protect you from something really bad. And, we are more apt to pull the trigger on things like imaging and quicker to refer when we have a kid and an athlete. And when you have a youth athlete, we're even more predisposed to do that. So we just kind of have a long discussion. I take him through a full exam. Again, this was a month ago when he came to our office. Cannot reproduce pain at all. We even get to the point of doing like 20-inch box, jump down rebounds, all this stuff, no pain. The only thing I can kind of reproduce is like a little bit of like sural nerve tension. So call it an aberrant, neurodynamic test, and send him home with just a neurodynamic kind of tensioner flosser for that. And basically was like, you need to start running, just thinking that he kind of has this, fear avoidance behavior. Well, he came back into the office yesterday and is now another month out from what I thought was running and all this stuff. Cause I actually heard from another patient that, he's so confident. He's like back at it. He hasn't really run except 3 times. He's only run 2 miles and he's had he says a 1 or a 2 out of 10 in pain. And then he just stops running at 2 miles because his foot hurts like a 1 or 2 out of 10. And his mom brought him in this time instead of his dad. And his mom is a little more aggressive than his dad in terms of what she thinks he should be doing in terms of running, getting back at it. So we'd have another long conversation of, I think you need to get back at it and just start running. Let's go through the exam again. And now his pain has moved again, which is the other positive thing in my eyes of like, hey, if we had the pathology, like the pain should show up. So basically they were supposed to get an MRI today because this person was in the clinic yesterday. And I said, I completely disagree with getting a follow-up MRI unless you get an MRI on both feet, just for a comparison study, because you had, another MRI 6 weeks later, it showed the exact same bony edema. You're taking all this time off, and his mom agreed with that. So this is one of those scenarios where somebody enters our clinic after they've been to a bunch of people, which is common. And again, now this went ortho, PT, right at the same time, dual, had not been back to, or then, follow up with the ortho for the follow-up MRI and then into our office. Then, expecting something different, this is where you have to make a decision. So in our eyes, we're always trying to do the best thing for the patient. Sometimes that's not treating them at all. Sometimes it's immediately referring them. Sometimes it's knowing, let's give it a trial of care. We don't know if we're going to have an absolute positive outcome, but if we don't, we know this is the next step. Or, hey, as you're going to hear some other cases, like I know you've been told some stuff and this might be a lot easier than you think it's going to be. So again, this one is a little bit different because why? I didn't do really any treatment per se because I thought that was, and Evan, who's a student in here, listen to this today, can attest to, is I just said, I think that validates that something's wrong with you. And I think that's the worst thing I could do right now because I don't think anything's wrong with you. I think you're having pain. I'm not saying to completely rub dirt on it and run through it, but I think if I go after some dysfunction or something, not that I would be making it up, but I think that would be damaging to him. Because there's always something to work on with somebody, right? Pro athlete, whatever it is. So that's a little bit different. So I guess the highlight of that story is starting at the top of, the non-conservative musculoskeletal triage pyramid, if you want to call it that, cannot be the best option. And then also sometimes we're not treating you just because you come in with aches and pains. There's a lot of times where like, you're going to be okay. And what you don't need to do is spend time and money with us, even though you're not perfect, because perfection is rarely attainable or even realistic. So yeah, it's a very different case, but it's not uncommon in particular with youth runners. These guys have seen me before. Like I would say a common one is medial shin splints. A runner comes in with that. They're just getting into running 7th, 8th grade. I'd say that's kind of an amateur injury. You're just, getting used to things. And I'll literally be like, hey, can we just run another 2 weeks? And if it's not better, it's getting worse, you can come back in. Because I think that builds confidence in the kid or at least saves money. And then the parent kind of has a little more buy-in with us. It's a different case, but I'd say backwards triage on that one for sure. But we'll see what the flyer there is. If that MRI shows something again, now who knows what his mind's going to do with that. And then we kind of had the discussion, well, what if there's nothing on the MRI and you go out and you run and there's still pain? So there's still some reconciliation, which we had a long combo about, like pain neuroscience and just what the next steps are.
Is he scheduled to come back in?
No. So both times I've seen him, last time I saw him, I said the only time I want to see you is if you are not getting better, you're getting worse. Well, the other thing that didn't happen is I suggested you do that kind of neurodynamic central nerve work. I said I would be doing a lot of plyometric jump roping to test your leg outside of running. He didn't do any of that, which was frustrating to me. He tells mom was frustrated. His mom's a personal trainer, so she knows all this stuff. So then his mom was barking at him, well, you can work out with me, which you could tell he was thrilled about. Yeah, so I was just like, I didn't prescribe that, but if that's the best option, that's the best option. So yeah, I didn't tell him to come back this time either. I just said, keep me in the loop on the MRI, what's found. I mentioned Dan Marvin, who is the nurse practitioner that we work with that does pain counseling. Because I said, he's just basically giving you tools to determine, is it pain, injury? And if it's pain, how do I, change my relationship with that pain in the face of, in particular, with this guy being an athlete. And kind of how I explained it to him was, this could be the best thing that happens to you before going to college athletics, of trying to figure out what is pain or an injury, because you're not going to have maybe a world-class team around you. You may not have as much time spent on you, specifically, because there's a lot of other people that have to get the training staff support, and you might have to figure out, do I push, do I stop? And if he's hitting the stop button way too early, it's going to be the worst thing for him in college, because he'll never run. He'll be little nags of pain will stop him all the time. So it's just tough. Any other feedback on that one or questions? Or trying to think if I missed any of the high points. We had we had hour conversations, both visits. So it's not like, we left with, it was just me repeating myself 15 times. But who's up?
Well, I'll jump in because I don't have a lot to say, but it was, I feel like an interesting topic. So I had a family that I was treating where I treat everybody in the family, or at least like in an extended family, everything. And it started where I think I just started treating his wife and his grandmother-in-law. And then he came in. So story is, patient came in, dislocated his shoulder 10 years ago. And then they kept asking me if I could do anything. I was like, I don't know, he had to come in for an exam. So he came in. I ran through every ortho is negative. But within the last month, just sleeping, he had dislocated it in the middle of the night.
How old?
Mid to upper 20s.
Okay.
And it had been going like that for the last 10 years. So I said, here's some exercises. I'm going to order you an MRI, and then let's see what the MRI looks like. And then he came in for his second visit, and I was like, basically, based off the way that it's healed, it's like, you have to have surgery. And so we're over a year out now, and he had the surgery, PT rehabbed, and then now he's back to normal. No more dislocating his shoulder. So like that was just a scenario where he came in. It's like I was able to test it out immediately and get the image. So then it's like I could at least see what a week did. And then after seeing the image, it was like, based off how it healed and it being like how long it had been. Then I was like, you need surgery.
Well, and I think that's a common question for us. Again, if patients are listening is, do I need a referral to see you guys? No. You can order imaging. Like, I don't think a lot of people understand or appreciate like primary portal means like you can just come in and we're running the show unless it gets out of our scope of practice, which is, anything, we can order labs, we can order all imaging. It just gets into injection surgery, higher order stuff like that. Certain tests we can't order just because if we can't treat the thing, even if we could order it, I still don't like us to order it because if you don't have an intervention at hand, why are you ordering it in the first place? Because like we had a person that was wanting a brain image for a specific reason. I was like, I don't know. So yeah, in that scenario, we've had numerous patients, like the writing's on the wall from day one. You're like, I don't want you to have a surgery. I'm like, literally, that's the best thing for you. But I also think, as one of our mentors, Brett Winchester, says, like, that is like why people appreciate us is like, if you are really good at triaging, that's almost better than being world-class at treatment because you're not going to be able to treat everybody. So if you're triaged on point, then like you just expanded your scope of basically taking care of more humans in a better fashion.
I will say, and I feel like it helped the rest of the family. So it's like they could see how quick I'll pull the trigger on, yes, you need surgery. Or they could be like, if he thought I need surgery, he would have already pulled that trigger.
Yeah. So. And that's a good point because, you have a 20-year-old, family still more or less involved in that. And, building confidence of just not, hey, we do chiropractic, right? And we're going to do that for everything in, house, which that goes for also, I would say, because I don't think we have any cases of this, is like triage within our own walls. functional medicine, getting somebody over to the gym when it's not necessarily like a treatment-based case, even massage therapy. Like I've had people where I see them for a few visits and I'm like, this took a long time to get this way. And I could sit here and do 30 minutes of soft tissue and have it accommodate, but I could give you a lot of home-based rehab and you could see somebody that can work on you for an hour at a time. That's actually more beneficial in my opinion from both time and economy standpoint. We try to use all the tools we have in here as best we can.
What surgery did he have?
So basically it had a tear in his labrum, and then it's like the way that, I think it was Dugas, the way that he repaired it, because the way like it had healed back, so like made it to where he couldn't fall asleep and dislocate it anymore.
Which is not uncommon. So one of our old athlete ambassadors, Zach Andrews, was a collegiate baseball pitcher at Montevallo and dislocated his shoulder, getting dogpiled after they won the College World Series, and was recruited by the Tampa Bay Rays and basically kept having recurrent dislocations and was pushing his mountain bike uphill one day and it just like popped out, and he used to be able to just like pop it back in, and he's like, I couldn't, and he just like came into our office with his like shoulder dislocated. I goes, it hurt? He goes, not really. I was like, that's not good. He was like, he had to have surgery within like 3 days because it was just like you have no like integrity left within the joint at all. Yeah.
And I'll say this, it's like I think I've seen some with bigger tears, but it was more recent in the injury.
Yeah.
And so like I feel like the duration.
When that I would say that's harder. Because then you're like, well, can I make change because it's more acute and, so they may have more instability. You're like, how much could I do? But yeah, I guess if it's significant enough, it also tells you where you're going.
I guess, again, like what is there an age that you wouldn't pull like the trigger on for like a surgery, potentially for like a shoulder labrum or something like that?
In that scenario, no, because I don't think you're going to see that as much in an older person because tissue is going to be stiffer. That's probably already happened. And if you had enough trauma to have that happen at that age, it's probably going to happen around the initial trauma. I think you get somebody that's 20, fairly flexible, soft tissue's pliable. That's where you get a lot of play.
What if they're still growing, like someone who's like 10, 11?
Yeah. So Seth's saying in the case that he has where an 11-year-old baseball player, I think we have a labrum tear in the shoulder.
Yeah, and he also complained that he had like his shoulder feels like it pops out, and like we can be on the table and you can feel his shoulder just like it'll just like clunk forward, and
it does get tough, which we've talked about this, but in that scenario, what we kind of discussed too is like my wife has what's called a Buford's complex, which is basically a rudimentary glenohumeral labrum. She didn't know this. Would have been great to know before she had 4 shoulder surgeries, and was a collegiate gymnast. That's what knocked her out. Is basically you have your glenohumeral joint's already very shallow. So we always call it like a golf ball on a tee, and then the tee is even shallower than it should be, and there's less labrum or suction cup on that joint. And, if he had something like that, like the kid's getting surgery because now he's had an acute trauma to it. He doesn't have the complex. Now, let's say it's a mild tear, and because again, the synergistic change around the shoulder is usually what's creating, repeated subluxations of it. So yeah, it's just kind of, what is it? Is it structural or is it functional is why he's having problems with it. And then is it also that he's been trying to play baseball? And, so I'd say, you just take the whole picture. And if you think he's going to have that many problems because he's 11. So
it's just because his shoulder feels different than the left side.
Yeah.
Or I guess the other side he's not throwing with.
And the thing is, you have to take into account, okay, what would he have to do to accommodate for that? So if it's going to make, he's 15 and he's torn through 2 rotator cuffs, I'd say the surgery now is actually worth it. Tough thing is he's still growing, so growth centers are not completely ossified or on the tip of his humerus. His soft tissue is not as, basically as developed as it could be. So there's just a lot of ifs that are pretty tough there. But that's also why they're pediatric orthos and not just orthos, because they might have a different approach, When's the last time you saw him?
Yesterday.
How was he doing?
He's doing better, but I also haven't had him throw yet.
Which he just might not be able to play baseball for a while. That
sucks. I have him throw him tomorrow because I'm going to see him again Thursday because he's got games Thursday and then tournament this weekend. And I haven't had him throw for like a week and a half. And so I was like, I want you to throw at least a little bit, just like warm up, not long toss, just see how it feels going through the motion of throwing. Mm-hmm. And then based on that, I told him I let him play Thursday if he has no issues. But then he also pitches as well. So I was like, but you're probably not pitching.
Yeah.
At least through the tournament.
Yeah. I don't know. my thing would be like Austin Einhorn, which we talked about a lot. Piros and Evolve Coach talks about like the throwing, the eccentric deceleration of the posterior shoulder and throwing, and how much you have to actually have a healthy shoulder, which he just gets into single arm hanging as kind of a proxy of like, if you couldn't hang for 30 seconds and you think like you can't do that and you think you're going to throw, he goes, if you don't have an injury, like you're set up. If you do have an injury and you're like, that hurts, like it's probably no go. So I think our job also becomes how well can we test in here without just throwing them in the gauntlet, which is tough.
I know it's not the goal of this thing, but like I also like the reason I let him go back to throwing is because I had him go in there and we did some like med ball tosses to at least see how his shoulder felt doing that. And we did like 3 or 4 sets of like 10 with like a 10-pound weight or a 10-pound medicine ball, and he was fine doing that. So I was like,
well,
I know it's a little different, but it's still the finishing motion, which is what started in the first place.
And I wouldn't say it used to. It still is. We used to tell everybody we talked to is like, we're trying to keep you in the game while you get out of pain. Like that's where you're really good at. Still are. It's just we don't push that as much. We're trying to keep people out there because I think pure rest is ridiculous for the most part, but then getting out of a sport isn't necessarily the best thing for people's mental space, and even healing. Being around other people can be better. But yeah, I mean, our first thing with any patient, in particular kid, is protect, and then you got to kind of work backwards from there. Any input on the baseball side?
Well, I was going to say just the fact that I think it's just so good now to look at every kid like, is this my kid?
Yeah.
And then like, I know if my kid's at 11 and they're playing baseball, it's like, I'm probably on like a lesser image or something is just so, I guess, horrible in every facet. It's like, I'm at least going to go 2 or 3 months. Like, it's like I want my kid or your kid to go all the way.
Yeah.
It's like I want them to go to college further. So like I would look at them as in like, can I load you? Like, let's look at this in the span of 2 to 3 months. And it's like, if I continue to see change, it's like, let's keep on going. And then let's answer those questions later on. Like we don't have to answer those today. Mm-hmm. It's like me and Beau, I don't know how many times we've had those talks about different people's kids. And it's just like how hard they push them now. Mm-hmm. And it's just like, you may be ruining their career later because we cared about this 1 weekend tournament.
Yep.
So again, that's like a conversation I had with him and his dad, just for like people listening as well. Of like when I'm shutting him down. So I shut him down because he also is, like I said, he's 10 years old. He goes and he's been since February until last week. They've been playing tournaments on the weekends. So they have up to 4 games if they win. Then they have other games during the week where they're playing 2 or 3 games during the week, probably like a Tuesday, Wednesday, Thursday, turning around doing tournaments again on Friday or on Saturday, Sunday. So it's just been that cycle over and over and over again. And now it's like they're finally into the season. I looked at him, I was like, hey, I want you to be better, 10 years from now. I don't want you to be the best 10-year-old athlete. It's kind of like, let's just go ahead and give you like a chance to take a break. Let's work on your shoulder a little bit, see if we can't calm this down, get ahead of it. And then if it continues, going further, sure, we'll look at imaging, but let's just shut you down for right now. Because I told him, I was like, there's like 2 reasons of like why a kid right now wants to come and like be seen and not play. It's either because he doesn't want to play or because something like he just needs some rest. So I was like,
yeah, I think both of us would say I'd pull the trigger on an image in a kid that you're like, I'd say anytime I'm pulling a kid out of sports, there's probably an image attached to it at this point in my career, just because of the only reason I pull people out of sport, unless it's something like Sievers, which I think it's a hard one just to not rest people and get them out of it. I don't think you should image Sievers, which people do, which I think is absolutely ridiculous. Yeah.
One thing, like one final note too, is like, say if you could pull up his swing or his pitching, it's like, I think it'd be great too if you're like, this is your season you're in, like look at your kinematic sequence, do all these movements so that when you are ready to play, now it's all easier to train all of that.
Especially at 10 or 11.
Yeah. And so now they're looking at it for the long-term picture, like, okay, I want to be the best in high school and the best in college. Like, I want to go to the show, all that.
Yep. What's your real case?
Yeah, that wasn't my case. That was different. Sorry. There was just, felt like that was good stuff we could talk about. Like, different age levels of like, 2025 is different than someone who's 60 versus someone who's like still developing.
Yeah, our 60-year-olds, we just like put them out back and we're like, hey, just ride a bike for 20 minutes. We'll be seeing 5 other people at the same time. And yeah, we'll bill you a lot of money.
We'll be like, oh, watch the hill.
Sorry.
Bridget, he won't be coming back in.
If you're listening to that and you got triggered, you're not very good at your job. So that's all I'm saying.
All right.
You're up.
I am up. Sorry, I got tape again. All right, so I had 36-year-old male came in. Been seeing him probably like 3 or 4 weeks at this point. But background on him, he's been in the military since he was 18. He came in for low back pain. He's been having low back pain for the past 10 to 15 years. He goes, I can't really put a finger on it, but he goes, ever since I got in the military, he goes, my back's been hurting me. But that just kind of goes back to some of the training they've been doing, like basic. And he's like, it never was like bad enough. I could just feel whenever I've been walking around a long time or been wearing like, packs on my back, whatever it is, I kind of have some back pain.
I just see your note. Do they call it parades?
He said something about parades that they have to help with. So that's all. Look, I have to write down what comes out of people's mouths.
Yeah, that's what I was just asking.
I'm sure there's a different name, but maybe he dumbed it down for me.
Yeah,
which is kind of always nice.
Yeah, ask my brother-in-law. See if they do parades.
I don't know what. He just said that he does like sometimes like parades or ceremonies, and they have to stay in attention for a long time. That's all I know.
Yeah.
Anything else you want to
Proceed.
rip apart before I even get into it?
The same word.
Did it?
Yeah. So I walk in the room and I just asked him, how he heard about us. But then I was just like, so tell me kind of a little bit's going on. He just hands me a sheet of paper and he goes, I think this will explain everything you need to know. Open it up and it's like an image. He's like, I got an MRI about, I guess the day before he came in or 2 days before he came in. And I was like, he said, this is all like everything that's on my MRI, like the report of findings or whatever they found. And I was just like, hey, thank you for bringing this in. I said, I'll take a look at it when we get done. But I was like, I kind of just wanted to do my history first before I fully take a look at everything. Cause I don't want to, narrow myself or put myself, what do you call it?
I'd say bias.
Bias. That's the word. Bias myself towards, one, yeah. And so he said, yeah, that's cool. So he's been having, like I said, 10 to 15 years. He has pain in his low back. Biggest thing for the MRI is he just told me flat out. He goes, because after I told him, I was like, let me do my own exam. He goes, well, the image said that I have a disc bulge, like 2 different levels. And then he said, then they told me I had like some disc desiccation. And he's like, I looked that up. And he's like, I'm scared that, all my discs are starting to dry out and I don't want to be, at that point because I feel like I'm too young. And then they said that I needed to come back potentially to, if it continues going on, either it's going to be surgery or it's going to be something that I have to just like manage for the rest of my life. And I was like, all right. So, kind of have an idea of where we're going like mentally for him. Go through my entire exam and nothing really stands out except for milligrams. That was like a little provocative. And then
No slumps.
No slumps.
Okay.
So just a little, just like milligrams, like just holding his feet up, he couldn't do that. And then whenever he had like rotate to the right, he had like a big deficit just on multisegmental rotation, which I feel like is kind of pertinent. And then have him sit down, cross his legs to try and rule out spine versus hips and all of that. And like his spine is the thing that keeps kind of driving of like he can't rotate to the right. So day one, I went after just like quick extensions, got a little bit of relief. And that's pretty much all I sent him home with. He also can't breathe to save his life. So that was kind of the first 2 things. But the biggest piece that I found after visit 2 was rotational derangement. So
For people that are listening, derangement just means you can't move into an area and it usually hurts to move into that position or movement direction.
He doesn't move well to the right. Let's just say that. So I had him just knock out a ton of those in office, went back, and he has no pain anymore through any of my other tests. Like, so he has nothing in milligrams anymore. He's not good at doing it. It just doesn't provoke any pain anymore. He's able to like actually touch his toes for the first time, and he's able to like rotate fully to the right. It's like everything kind of cleared. So I just after visit 2, talked to him. I was like, I know you mentioned having to go back and see an ortho potentially later on. I was like, at this point, I don't see a reason of why you need to. I was like, we cleared all of your audits on my side in terms of, what was causing you pain or what I thought was the biggest thing going on. 2, I was like, if we thought it was maybe more pathology, I was like, you would have pain either more often. You would be having pain either throughout the entire day or whatever I'm going after right now wouldn't have made the change that we did. And I also try to, talk to him about like what the disc degeneration kind of was, why it wasn't like a big deal, more so just how he's been loading himself, or I guess like stabilizing his spine more so. That's the other thing. He's really big into CrossFit, and he has no issues at the gym during CrossFit. So I don't know, that to me that just didn't make sense if he's able to load as much as he is. Oh, he also got told by the ortho that he saw that he, for the rest of his life, needed to not pick up anything over 50 pounds. That was the thing. That was the thing I was trying to go for in this case. Mm-hmm. Yeah, he got told he couldn't pick up anything over 50 pounds in his entire life. He looked at me and he was like, that's not even possible because my dog weighs more than 50 pounds. He's like, so if I pick up my dog to give him back, he's like, what? So I'm just like waiting for my spines to blow out. And I was like, well, it kind of makes sense.
I would have just said yeah and like walked out. Like, sorry.
I can't help you here.
Yeah.
Guess your dog's going to have to be a cat.
Yeah, that's the biggest thing. So now we're on visit 6 or 7, and he like has been feeling better and better each time, and we haven't had this discussion anymore of, he doesn't have to have surgery, doesn't feel like he needs to have surgery.
There's a couple things to break down in there. Is we all know this, but disc desiccation. How old is he again?
36.
So disc desiccation, maybe to that extent, is not normal for that age, right? So when we, the whole degenerative disc disease or whatever we're going to call it should be a non-ICD-10 coded diagnosis. It's just, now people analogize it to wrinkles on your face. It's normal signs of aging. That's not quite normal. Now, are some 36, 37-year-olds more wrinkly than others? Sure. So maybe for him it is based on activity or health, nutrition, all these things kind of play into it. Does it change arthrokinematics and pain signaling? For sure. Right. That's one thing we don't want to just like throw the baby out with the bathwater. It's like, oh, you don't have a disc? Like, that doesn't mean anything. But yeah, it does. It's no different than if you didn't have a meniscus. I think we'd all be like, yeah, that for sure changes your knee. That does not mean you have to have surgery, that you're in lifelong pain. It means that you manage it, which is the other part that needs to be addressed, is because on visit 2-3, the guy was kind of out of pain. You just said you're almost 8 visits in. So obviously you guys are still working on stuff. So that's like, it's not just like, oh, you're out of pain. I know you've had pain for 15 years. See you later. It is management. It's how he does things. It's maybe what led to what caused that in the first place from a functional standpoint. And that's the big driver in our offices. We're not chasing pain. We want to get you out of pain because it changed how you move. That's what you want as a patient because that's why you're in our office in the first place. But yeah, we have to kind of look a few steps further and kind of ask, well, why is it this way? And then we also have to kind of play with other people in our field and say, there's only so much that we can do. And sometimes we need help, whether that's pain management in the face of trying to change movement patterns and things like that. Or there's just a plateau and a shelf that you're just like, this is as good as it's going to get. And if you're okay with that, and I'm okay with it, we'll keep working. Or, hey, here's these other steps and we'll help, quarterback that as well.
The other thing too, is I felt like it was a big like motor control piece of it as well.
Yeah. If you're that age and parents,
just because he can. So the biggest thing that I found is like trying to do some little thoracic like openers to his right, like he's laying on his side. So he's just basically laying on his side trying to open up, right arm all the way across, trying to get his right shoulder blade to touch the ground, top knee, whatever side you're laying on, is trying to stay on the ground. He can do that if I take him there, but if he tries to do it, he can't. So then I was like, let's try and load this a little bit, challenge a little bit more. So I basically just put a kettlebell in his hand, did those loaded thoracic windmills. Couldn't do it at all. But if I hold his knee down, he can go all the way to the floor.
So what's that make you think right away?
Say that one more time.
He was in his own world.
He
was basically saying he has a stability motor control dysfunction in right rotation. Like he holds him in place, he can rotate. If he loads him, he still has to hold him.
And if I load it and I have him do it on his own, he catches like huge cramps through like adductors and that right oblique.
Neurovisual. All day long.
I was about to say, I feel like me and Beau talk about that all the time, where we're like, immediately when we see it, it's like, as soon as we see it, it's like, we're like, I'm at least going to check it.
In particular,
5 seconds.
Yeah, in particular, asymmetrical rotation, stability motor control. I would almost say that's what it is. Like, that's what's causing it. It just doesn't make sense that you have that otherwise. Stability motor control for like a toe touch could be fear avoidance, and you change it really quick. And maybe we're just using a bad name in that scenario. Like, I had a mom and a daughter that came in, they both couldn't touch their toes. We had to do a little bit different stuff. Both of them, they both touch their toes. Is that stability motor control dysfunction, or is that just like, you don't know how to do that? I don't know. Maybe it's the same name. You know what I mean?
Yeah.
But I think stability motor control for that is like, dude, if you have a weak peripheral field or the ability for your eyes to move in that rotary pattern or reflexive motor pattern, and then you hold him down, he's like, whoa, well, you took the restrictor plate off. Then you ask that next question, like, well, why is that happening? Right.
I guess that's a piece that, if you want to talk about things that like maybe I failed on the exam of like,
No,
I didn't. Well, I asked him when the last time went to his optometrist was, because I knew like in the military you have to have pretty decent like vision to like continue being like in the field.
Man, you don't even have to do a pull up nowadays, so they probably let anybody.
But he just mentioned I was like, when's the last time you went?
Guys.
Yeah. Well, Alex can't even see, like I'm sitting over here anyway. So, but I asked when's the last time you went to optometrist, and he's like, I went a few months ago because it's just for like their checkups that they have to do. And he's like, I have 20/13 vision, so I was kind of like, well, he's got like pretty solid eyes. That doesn't mean though peripherally, I guess.
Also, there's a big difference between visual acuity and vision function.
Yeah.
And that's tough for patients to understand, that like you get checked and they're like, oh, I'm good. And it's like, that's no different than you walked into our office and we can say, oh, you move fine. Like, yeah, I know you do. You breathe. We may work on how you breathe. Like that's kind of the thing that I think, because we've had optometrists say, oh, that's a bullshit. Like, when you're talking about behavioral optometry or, whatever you want to call it, neurocognitive therapy. Obviously, we know it's not. So I'd just say you didn't mess up. You asked those questions, but then I'd say, let's say you ask them all, you're like, yeah, it doesn't seem like that. You see that big SMCD poke out, you're like, yeah, I'm going to still load the pattern because it's going to help them move. And then like, if we want it to stick, quote unquote, I think you're going to either have to have behavioral optometry assessment or look at, some vision therapy in there or something. Maybe it's not that, maybe it's vestibular or, something else.
When I almost feel like it's so rare too. Like if you see the single leg balance and the rotation, it's almost every time like one of those two. It's like, you can break it out because it takes no time at all, but it's like, and then I think even like with like ZL stuff, he characterizes the eyes as in like there's 4 to 6. I can't remember them all off the top of my head, but it's like 4 to 6 different areas when we're looking at vision. And it's like our optometrists do a great job. They're looking at one of those areas. And it's like, that doesn't mean we can't train the others.
The other piece was he didn't have any deficits on single leg stance,
which throws me further to vision stuff.
Why?
Because he took away the eyes and everything.
Took away his eyes and it's fine, but again, he doesn't like. So now you're saying, well, he moves awesome except rotation, which makes absolutely no sense now. Say you have an asymmetrical deficit on single leg stance, could be vestibular. Then you got to run through CTSIB and all these other tests. Then I'm starting to be like, man, if I set this guy down, you're like, man, huge restriction. But I can take him there. I mean, I don't know. It would just be very earnest. You go in, you're like, oh my God, his right eye doesn't converge. You do 10 conversions. He just whips into right rotation. You're like, oh, there we go. Now, how do you treat that? Dealer's choice at that point.
I haven't been like using the eyes as much, but I've been doing sideline stuff, trying to get him to roll to that side. I have kettlebells. I have him like focusing on certain pieces in the room of like where I want him to like rotate towards. So I haven't like been not using the eyes, but have been using it as like my main thing. That's for sure. We're
kind of getting a field here, but if the eyes are a huge driver, the neurovisual system, whatever we call it, they become the main thing. So if it's like I can help them get there, well, instead of using like a band assisted opener, you'd be like, no, like I might have to drive them into convergence as I create right rotation or whatever it is, and be like, oh my God, that's because that might be the thing that he never did developmentally, or who knows, he could have. You can have literally lens issues, obliquities in your lens, all these things that could be causing it. And then that gets out of our realm, which again is a triage move of like, we've got people in our, community that we use for that. Yeah.
And I always feel like there's levels too. It's like you could just do a simple convergence, divergence, like not even do that complex drill Beau was talking about. Like that may be the perfect one for him. But it's like I also could just cover up one eye, do it, and then now I'm going to do that same drill you gave him, and I'm just giving a greater feedback loop.
Yep. Cool. Hit a bunch of points on that one.
All right.
The caboose. Come on.
47-year-old male. This was about a year ago. I had treated him previously for some neck pain, and he had come back in and he had come in 3 days prior. He had seen a different chiropractor because you and I had both seen him. We were both out of town, and you were full, and you weren't here yet. So he said that he went to see this chiropractor, and that guy gave him an adjustment, used a Y strap, and
ring dinger. If you're lay public, you probably know what that is. And awesome.
He put the towel around his neck and he yanked it. Okay. And as he was having that adjustment, his headache and neck pain symptoms increased, then almost had instant relief the day after. So he was feeling really good, but then again, his headache spiked back up. He started having, it was kind of changing location from this lower base of the skull, occiput area, to the top of his head. He was getting nauseous. So he took his own blood pressure, which he has mild hypertension, and he's been medicated for a couple of years now, but is somewhat active. He's not like the perfect patient of keeping his blood pressure in check, but took his own blood pressure at home and it was 170 over some number that I don't remember. But and then he went to see his primary care, ordered blood labs, revealed normal findings. They increased the dosage of his current blood pressure medication, and then had put him on another one. So he increased that, did not see a change in his blood pressure from that point on several days thereafter. Mentioned that he had another appointment with some other doctor at UAB that morning, or a telehealth appointment coming up, and his headache was still the same. Only gets relief by putting ice on the back of his head. And so I guess I chose this case thus far because if any of you who haven't been to the farm somehow are listening to this podcast, or if you've been to the farm and you don't necessarily know how to explain why we're different than other people, right here. This person did not do an exam. I asked the patient, I said, so did they do an exam on you before they did the adjustment? And he said, what do you mean? All those things that we did at the beginning when I first, we checked range of motion, I did the reflex stuff, all of those things that we check on the first day, did they do that? He said, no. So I was like, all right, this person, having never seen this patient, didn't adjust or didn't do an exam, adjusted them, didn't know that he had mild hypertension, was having neck pain. He also mentioned, I said, were you having any discomfort on the side of your neck where I was kind of pressing around? He goes, yeah, actually it's really tender if I touch right here. On the side of his neck. I said, okay, that's not a good thing. So needless to say, he wanted me to adjust his neck that day. And I said, I am not adjusting your neck. This is literally what got you in the situation. We did work on his T-spine, so again,
which is important to know why the neck pain started because of what you worked on. So he was carrying basically shingles and plywood.
Yes.
He owns a roofing company or construction company. Somebody couldn't come to work, so he had to carry plywood and shingles on his back, and he literally said he was carrying them like this. If you're watching the video, like on the back of his neck, like that, and then he started having kind of a suboccipital headache that was pretty bad.
Yeah, kind of like you going up Hostel.
Yes.
Yeah.
Yes.
Yeah, exactly.
So, this is way easier.
Yeah. So needless to say, I had him foam rolling his T-spine. We were doing a few things around that, and I saw him again. Missed a big point. We sent him out for a CT angiogram because I was thinking he potentially could have had an artery dissection, especially when he's pointing to that spot on his neck. That all came back fine, but granted, could that have been the case had we done the CT before he came and saw me in between that time? Absolutely. The next time I saw him, he came back and his blood pressure was back to normal for him, which was 130-ish over 90. He was back to doing physical activity and was doing his stuff for the middle of his back. But I brought that case up because I know that we're different than a lot of offices around here, but it still baffles me that people will hear the exact thing that we were taught in school of, this is when you don't adjust somebody, when they're having these signs, and you say, maybe we don't do that today, we get an image. And then you say, no, it's just easy because I went to school to learn to adjust people, that I'll just adjust it. And if something happens, it's not on me, except it is.
Which is kind of like if somebody goes to the joint, at least they're overt about it.
Yeah.
Like it literally says, we don't do an exam. And which I get why they do that. It's a liability play for them, but it's also like, what you're getting into. That chiropractor, which is in our community, so, throw a dart at a bullseye, you might find out who it is, but we don't care. But that is terrible for the reputation of now you are primary portal of entry as a healthcare provider, and you're like, yes, wrap a towel around you, rip your head off.
You don't learn that.
Yeah, that's not a move that is taught in school. First of all, it's just popularized with old whatever the dude's name is. Yeah, ring near. Yeah, so that's not taught in school. You're taught how to do an exam. Are people, even though we're taught how to do an exam, are people, really good at it? No. When you get out of school, I think you're just okay at it, which is a problem too. And then you have to get out and practice it. But then practicing a musculoskeletal exam and picking up non-musculoskeletal ailments in the face of that could be very damaging, deadly to somebody, is why we still right now hold the physician moniker, and may not if we have more people like that doing that crap. So that's where it kind of gets us riled up. But we want people to know that, like, if you go to somebody, you get this, like, even 2-minute exam, or let's say you just get x-rays and that's the proxy for the exam, which is, I would say, way more common than just, an exam.
Yeah.
Say we did x-rays, there's really no exam. Yeah, that's what's going on. And you know where else that's common? Orthopedic offices. So literally, I'm seeing a guy right now that was told he needs knee surgery, canceled his orthopedic follow-up because he's doing better, even though his knee is not awesome. And he has said this 3 times now. He goes, I'm canceling, because he goes, that guy never even touched my knee. So no physical exam, which, matching physical exam to imaging, the physical exam is higher order than the imaging because of what we can pick up on an image and what that denotes for functionality. And then, the writing's on the wall with that. He's like, yeah, I didn't touch my knee, so I expect I'd have the same thing this time. And he goes, I'm going to go in and say, it's doing better. He's not going to touch my knee. He's probably going to, see you later and bill me. So it's like, I'm not opposed to that. I didn't tell him, one way or the other, but that's where I'd say it's more common, is there's not a physical exam. And if it's done by anybody in the office, it's usually not even done by the orthopedist. It's going to be done by the MP or, resident or somebody, which we have people in our profession that run their offices like that. And I take issue with that to a certain extent, because there's no way they're trained to pick up stuff like we are, or you're losing your ability to do that if you're not practicing it every day. So that'd be my 2 cents on that part.
The other thing is, like you said, the physical exam is higher. Like, even going through the pathology classes we take, physical diagnosis, like, all of them are pretty much what you would see visually or what you feel. Almost all of the classes, like everything on a slide. Like, you never see anything of like, hey, if you pull an X-ray, you'll probably see this. And you might see that in some of your your diagnostic imaging classes, but
and again,
outside of that, it's like,
because they're, the order of operations for examination is physical exam first. That would lead you to imaging, but that's not how the medical system worked for the past 50 years. It was image everybody that came in. If you're an ortho, MRI, X-ray for sure. Primary care will pull an image as soon as you mention musculoskeletal. It's not, hey, let's see what's going on, and hey, I need an MRI because you have an ACL. The only place that really happens unequivocally would be athletic training, which is kind of interesting, right? Like, they kind of get thrown on their bus. It's like, no, physical exam first, because they have to be really good at it. And then I bet they're among the best of picking the correct imaging, right? Which has to be signed off by for a physician, but being like, yeah, I think they need a MRI because I think their ACL is blown, or let's just get an X-ray. I think they got a chip fracture. I bet they're way better at that than most people. Yeah, so that's a good case too. Any additional comments? Please for help. Anything? So if you're listening to this and let's say you're a patient, you're not in our community, we can always help you find somebody around your area that practices like us. If you are in our community, stop by the office sometime, or let us know what you'd like to hear about on the show. We talk about a lot of high-level, fun, nerdy doctor stuff, but we can talk about more patient level as well. And if you're a physician, student, listening to this, again, you can go to anthroedu.com. You can submit a case if you got an interesting case, you want help.
Thank you for tuning in. Please subscribe via YouTube, Apple Podcasts, or Spotify. If you like the message, please share it. We appreciate it. Thank you.